Thank you very much. Yeah, thanks for the introduction. And I agree, maybe, this was really the introduction to, not underestimating ADCs in the context of all the excitement that we had rightly had with bispecifics and CAR T cells. So, because what does an ADC do? I think it's, as such, a very compelling mechanism of action. You can see ADCs, in principle, those directed against BCMA bind, of course, to the receptor on the surface of the cell as other drugs, but then get internalized and release their payload, the payload being normally something that is a cytotoxic drug that's that's very effective against myeloma cells, and think of it as something that is really a Trojan horse that allows the delivery of a drug that is highly effective, maybe similar, it's not melphalan, but something like melphalan that doesn't hurt all the other cells around it, but really targets only the myeloma cell. And then you can think of that is a very effective mechanism. So, as we've already discussed, there is, of course, several ADCs actually in development across cancer. There are hundreds. I think it's a very interesting concept, which tells us that already belantamab mafodotin is the most advanced one, which data from phase 3 trials already read out. But there are other drugs that you can see on the lower bottom that are currently still in development. And I think we will hear and continue to hear more about ADCs, maybe not even only against BCMA. The clinical trial data that we have so far, and this is really the exciting news that we've heard from the DREAM7 and DREAM8 studies, and I'm starting here with the DREAM7 study where belantamab mafodotin was combined with bortezomib and dexamethasone and compared against DVD, something that we, for example, use very standard-wise second line at the moment. Still, you can see here not only a really, really marked uplift of the overall response rate from 71% to 83%, but also a really marked uplift of the CR, so CRN stringent CR rate, and MRD negative rate, actually, really, really deep remissions from just below 10% to nearly a quarter of the patients reaching CR and MRD negativity. That's really a very striking result, I find. And what we found very, very, for me at least, absolutely novel data, because it's the first time that we're really seeing a triplet combination compared against the triplet combination. All previous trials were 2 drugs versus 3 drugs. We're having here, in some sense, the purest and also the hardest way of how you can compare drug regimens, and you see an absolute strong uplift really striking uplift of the progression-free survival to 36.6 months for the belantamab, bortezomib, dexamethasone combination, compared to actually just 13.4 months, which is actually quite comparable to what has been reported before, but really markedly shorter for the DVD combination. And we should not forget in this regimen, of course, the bortezomib stops at some point. So for me, that's definitely a sign that belantamab is a drug that has inherently a higher activity, because from these 13, 14 months onward, it's only the 2 drugs, daratumumab compared against belantamab, if you want so. And it really retains the shape of the curve even beyond bortezomib dropping out. And as you can see on the right-hand side, that data is still immature, but there's a positive signal about overall survival already. So if we look about toxicity, actually many of the toxicities that we are very, very aware of and very normal, we're used to dealing with, are pretty much similar. Infection rate is a little bit higher with the belantamab combination, but not in the scale of how we are seeing it with bispecifics, for example. There's a bit of thrombocytopenia, which I think is mostly focused on the first cycles of treatment. But actually, they're all toxicities that most of us are very familiar with dealing with. What is, of course, new is the ocular events, and I think it's worthwhile spending more time on that, because I think there has been a lot of confusion about this in the past. So actually, there is ocular events in that there is corneal changes, and I will come to that in a second. And I think what we're seeing probably as the most is that patients tell us that they have dryness of the eye, but that they might have visual impairment. And that visual impairment is by no means anywhere close to very serious in most patients. Most patients get a visual impairment that you can see here in the middle. I'm not sure whether my pointer will work. Yes. That is a mild visual impairment, but what is the important thing is, for nearly everyone, that visual impairment goes back to here if patients pause therapy and then reduce the dose. Many patients had to pause therapy, but very few patients had to stop therapy, and actually with the pause alone, this goes back to normal. And there were only very few patients, as you can see, single-digit numbers on the right-hand side, that had higher impaired vision. That's of course not great, but actually also all of them actually went back to baseline or at least an improvement. Now it's nearly striking. Why does that happen? You know, we're hearing about other side effects with other drugs. I think this got slotted in some minds into the wrong direction, because we're actually underappreciating that our eyes are highly regenerative. It's nearly like a fingernail or hair. The cornea, where this drug is actually getting incorporated, grows constantly throughout our life. This doesn't stop. This is just one of our usual processes because it's exposed to the outside world all the time. There is a stem cell zone at the rim of the eye, and then the cornea regrows all the time to the middle. And actually, even if a belantamab mafodotin gets incorporated there, it will grow out within 4 to 5 weeks. And that's the reason why we're actually having restorage of normal vision in all patients, nearly all patients in the trial. If we go to the other data from the DREAM-8 trial, this was belantamab with pomalidomide and dexamethasone, and interestingly here, of course, a combination that was a comparator that was daratumumab-free, so bortezomib, pomalidomide and dexamethasone. But as you can see also here, an uplift of the overall response rate, but again, particularly a marked uplift of the complete response rate with MRD negativity from just about 5% to, again, a quarter of the patients. And again, a very fair comparison, 3-drug versus 3-drug. I think this is really unprecedented and should be for us a milestone in how research is done in myeloma. And again, you can see a really marked uplift of the progression-free survival. In this case, the median progression-free survival is not even reached, and also a positive overall survival curve. And just to make sure, you know, this is really reproducible, that the eye visual impairments that we are seeing in some patients are again nearly completely recovered in nearly all patients, also in this study. So it's not anything about just one combination having different toxicities. This is recoverable. This is regenerable. As such, and this is really speaking towards the experience that we have made with using belantamab in the compassionate access program very widely in our practice as well. So I think just also to notice and to mention, I will come to this later, DREAM-7 of course used 3 weekly belantamab infusions, DREAM-8 used 4 weekly belantamab infusions. The visual impairment rate is relatively similar across the two, and I think many patients in both trials had to pause treatment, maybe indicating that we should even go maybe to less frequent dosing in both drugs. But what is really important is that in the quality of life, we can see no impairment really of the drug. So I think it reflects again what we're experiencing in our standard of care as well. The visual impairment is not a toxicity that our patients necessarily find highly impacting their daily quality of life. So this is hinting again at whether other dosing and less frequent dosing schedules could potentially be in the future much more widely used with belantamab. Of course, we will have a label that includes in the first instance what is in, or we're expecting that, we don't know it yet. But this is a trial that the Greek group were running in elderly patients, and they were stayed from the beginning exploring 8 weekly dosing with belantamab. Here, this is a frontline setting. It's not quite comparable with the data that we have just seen before, but again, it's a combination of the drug with lenalidomide and dexamethasone. So I think not too dissimilar, at least from a combination with another IMiD. And I find the data for the reason quite striking. A, with the 8 weekly dosing, we have 100% response rate nearly in all cohorts. And you can then see there's even dose reductions in the different cohorts. And it doesn't really make much of an impact on the response rate. So it is for me an indicator probably even less dosing or less frequent dosing with this drug will still have very high response rates. It also replicates what has been observed within the trials of DREAM-7 and DREAM-8. When patients had to reduce doses, they still experienced the same efficacy of the drug. So just coming briefly to the mechanisms of resistance, we know that the other BCMA-targeting drugs, CAR T-cells and T-cell engagers, bispecific antibodies, do inherently need the T-cells to work. And of course, T-cell exhaustion can be a mechanism of resistance. And that's not the case with the ADCs. As I mentioned before, is there the incorporation of the toxin into the drug and the release of that. And I think that leads us nicely over to the data that's out there on sequencing of drugs. I think specifically here looking at the question, how did bispecific antibodies, T-cell engagers, work after exposure to other BCMA-targeting drugs? And there is actually a very encouraging message in here that the efficacy is still over 50% if we think back, even if patients have had prior ADC, prior CAR T-cell or prior ADC and CAR T-cell in the MajesTEC-1 study. That's very consistent with data reported also with belantamab. And I think many of these responses are long and they are actually deep. So although there might be a slight reduction over what the overall group has shown as patients, I think it's very, very similar to the overall efficacy and is indicating that we can definitely sequence this way around. There might be a little bit of a benefit for having a longer break, although I have to say I personally think that we need more data on that, and I'm not necessarily convinced about that. So the conclusions are that the belantamab combinations have demonstrated superior response and PFS in 2 triplet versus triplet comparison trials, which is really an absolute novelty and striking. In many regions, I think we are aware bispecifics and CAR T-cell therapies are not available in earlier lines, specifically not in second line, with label restrictions for the bispecific therapies. And the anti-BCMA ADCs, once they become available, could be really an effective option in early relapse. The most common toxicities are ocular, but I would say I would really try to think about again what we're talking here. It's a different type of toxicity that does resolve in most patients due to the regeneration of cornea. They don't depend on T-cell activation, and T-cell exhaustion is not a mechanism that's mostly driving resistance, so there is an open window for sequencing of therapies, and there's early data showing high response rates to bispecifics following the ADC therapy. So I think anti-BCMA treatment-free intervals might be beneficial in addition to the response to subsequent anti-BCMA targeting therapies, but probably not essential. So thank you very much.